my gosh. Hi, everybody. Hope you're having a great day. I think
Morning, Tanya.
I know I'm on the late freight, but just by a couple minutes. So, anyway, welcome everyone. Um, I just want to say it's a great day. It's a great day in the company. I hope you guys are feeling good and things are going well for you out in the field. We have lots of new employees. I just can't believe it. We are growing by leaps and bounds. We're busting at the seams, and I'm just so thrilled with the new talent that is coming our way. And I have to say that I have to say apologies initially for not recognizing Paul St. Juan. Are you on, Paul? He's our brand new nurse, and he's literally brand new. He's a new grad who is gravitating from LVN to RN, and his transition has been phenomenal. I'll just have to say I am just so thrilled with his progress. He's a month in, he's already taking starter cares and IVs, and that's pretty challenging. I know everybody wants to commend him for that because we usually don't do the new grads and do starter cares. And I also want to commend Mary Yee because Mary Yee is his preceptor and she's really pulling him along as fast as he wants to go, and he's going at such an amazing pace. So kudos to Paul. And we also have Diana Harege. She's our new MSW for the Santa Clara area. We have Elizabeth Bayer, who is an ST. I'm just going by my list, and I know there's more. Bridget Murphy, who is a PTA, and both of those, all three of those people are for the Santa Clara area. We have Summer Dixon, who is now a part-time MSW for the East Bay. We have Emmanuel Camino, who is an LPN in our area, and Guadalupe Velasquez, who is a home health RN travel. She'll be with us until the end of the year. Let's see, who else? Chris. Everybody else?
Melissa Hanson, PTA.
Pardon me?
Melissa Hanson, physical therapy assistant.
Okay, welcome, Melissa.
Yes, and we also have Katrina Menanquil. She's a PT.
Right.
She's going to be on team 2 around the Oakland area. And then we also have Rose Shapiro. She's a speech pathologist. And hi, Rose. And she's also in that same general vicinity. So welcome, everyone. If we've not mentioned you, it's totally an oversight, and I apologize. But I think we got everybody.
I think that's at least 10 to 12 new employees, across the entire region of the Bay Area. So as I said, we're growing leaps and bounds, and we're just thrilled to bring everybody on. And we lend you our support for success. So with that, we have some commendations for some employees who have been on. Say hi, Avery. You seem to be leading the charge here. Vince, as we well know him, it says, make sure that Vince Avery Velasco was sent directly to us as the supervising managers of the agency. She says he's an amazing therapist. She feels so much better now. He doesn't give up on her. If something does not work for her, he makes sure that there's a safe alternative, and he explains everything thoroughly to make sure she understands the process. So shout out to Vince.
Way to go, Avery.
Yes.
Thank you.
And then he gets it again from another patient who says, thank you for the terrific service for her husband, and also to Audrey and Fernaz, because you're such a great team. So congratulations, you guys get another employee recognition and a gift that's coming your way via email. Thank you for such great work. And we're not going to dawdle or delay. We have, I believe, Nia and Daniel from hospice who has a presentation for us. We want to be very clear about the process, understanding when to do these referrals, and we're actually getting increasing referrals, which is a really good thing. But we want to remind you about this service. Daniel, are you taking it away?
Yes.
Hi,
Hi, everyone.
There's Nina and
Hi.
Daniel. Welcome.
Good morning, everybody.
Good morning.
Good morning, everybody. So, I'm Daniel. I'm a director of social services with ACE Hospice. And Nina is also on the call.
Hi, Daniel. Hi, everyone.
Yeah. So today we wanted to talk a little bit about how to refer patients to hospice, and wanted to do a little bit of a hospice overview. So ACE and Home Health and Hospice were one company, and some of our patients on the home health side, they decline a bit, and they may go into the hospital, and then their diagnosis can kind of switch to something terminal after a hospitalization. They can become weaker, and
Hello?
they can relations. Can you hear me?
Yes.
Okay. And they may reduce their ambulation, or they may reduce their ability
Right.
to eat.
So did you call that
And
guy?
they can. Sorry, can everybody hear me?
Yeah, all right, folks. If you're not speaking, can you just mute yourself unless you need to ask a question? Go ahead and mute yourself, please. Thank you.
All right. So hospice care is a specialized form of end-of-life care that aims to provide comfort and optimal quality of life for those facing life-limiting illness and terminal diagnosis. So we are different from palliative care in the sense that the patients that are on hospice, they are considered, or they have been identified to have a life expectancy of 6 months or less to live, if the terminal illness continues to run its course. And it's also for patients that don't want aggressive treatment, including hydrations or hospitalizations. So what separates hospice from home health is about, rehabilitation. We want to get stronger. So we want physical therapy, OT, rehab team to come in there. We want to improve, our medications. We want nurses to come in there to assist us, check our vitals. But on the hospice side, one is identify that, I no longer want to seek aggressive treatment. Now I just want nature to run its course, but I want a team that's going to help me to manage my symptoms, manage my pain as I continue my trajectory, and, as I continue to decline and die naturally. Uh, so wanted to talk about, the key ways to communicate that with the team. So if a physical therapist, for example, identifies that a patient is now getting weaker, you can communicate that with our case manager, who can then request a hospice consultation. So this is some of the declines in clinical status. So a progression of their disease, like worsening of the conditions, or if they have recurrent infections, if they have significant weight loss in the last 3 months, if they have increasing symptoms of shortness of breath, if they're experiencing nausea, vomiting, or increasing pain, or if they're declining in functions, and they're no longer able to tolerate physical therapy or rehab in the home. If they've gone to the hospital multiple times in the last month, maybe one individual keeps going for COPD exacerbation. They can't get their breathing under control, so they keep going back and forth into the hospital. Or for example, before they were able to hit up their food independently, but now they stand up and now they become short of breath, just ambulating about 10 feet around the home. Or if they have a progressive stage ulcers, in spite of all the wound care they're receiving, they're now sleeping more, but for some reason that wound is just not getting better, and they're losing the ability to eat. So some of the comorbidities are COPD, chronic obstructive pulmonary disease, congestive heart failure, heart disease, stroke, Parkinson's, renal failure, liver disease, and also dementia. So patients that have cancer diagnosis, for them to be eligible, they just have to want to stop seeking aggressive treatment. So you can have stage 4. The doctors have identified that you have stage 4 cancer. Let's say it is metastasized to, your brain, to your lungs, to your bone, to your liver. As long as you're seeking aggressive treatment and you're following up with oncology and you're receiving some type of treatment, you cannot come into hospice because you're still receiving treatment for your terminal diagnosis. But if you tell the doctor, you know what, I no longer want to seek aggressive treatment, I want to just stop all treatment, then you are eligible and you're able to come on to hospice. Another diagnosis is ALS. So ALS is a progressive disease and a progressive degenerative disease. So no matter your situation, you're going to continue to worsen over time. And, eventually one will go from ambulating to maybe to a walker to now a wheelchair and eventually bedbound and losing the ability to swallow and, on all functions. Another qualifying diagnosis is dementia, and that's Alzheimer's dementia. So when in their final stages, they can only utter less than 15 words. They typically are chair bound and are incontinent. So that'll be, you can check in with hospitals and say, hey, I may have a potential referral. Please come out and evaluate if this patient will be eligible. Also, heart disease. If they have a heart disease, but they are continuing to go to the hospital, and their ejection fraction falls to around 20%, that makes them eligible for hospice. HIV disease. If their viral load continues to grow and they can't maintain it, at some point, they can come on a hospice. Liver disease with liver cirrhosis can turn into end-stage liver, disease where, they now need hospice because no matter what, there will be no kind of treatment that can improve their current condition. COPD, if they're using oxygen, 24 hours a day, and now their liters are increasing from 2 liters to 3 to 4 to 5 to 6. They may be eligible for hospice as well. Also, stroke are stroke patients that have paralysis or dysphagia, so difficulty swallowing. Because what happens is they can aspirate, and with an aspiration, it can go into their lungs, which can then cause them to, go into the hospital, or it can, worsen the condition. And also, it can cause infections in them as well. So if you feel that a patient is having any of these criteria, you can talk to them about their goals. So I think the first thing is to find out, Mrs. Jones, you've been going back and forth to the hospital. You started with CHF, and now, your ejection fraction is falling, to around 20%. Home health may no longer be appropriate with you, and we have a higher level of care in our agency. I would like to set up an evaluation or a consultation with a nurse to see if you're eligible for that program. So, what are your goals? So, I don't want to go back to the hospital anymore. I just want to be able to spend the rest of my life, enjoying family, making sure my needs are being met. Oh, okay. Let me go ahead and refer you over to this team. They're going to come out and they're going to evaluate you. So that'd be a kind of an easy way to start the conversation with the family. Are there any questions, or are there any scenarios that you guys want to kind of go through to see if a patient would be appropriate for hospice?
There is a question out there, Daniel. It says, how do we contact hospice for a consult?
Oh, excellent question. So you can reach out to Nina. Nina is our director of patient clinical supervisor. You can reach out to Nina, and with an email, and she'll be able to arrange and coordinate a nurse to come out to evaluate the patient. Or you can reach out to myself. I can direct that referral to to our intake process, and and to Nina as well. But our clinical supervisors will be the first contact, so that way they can get out there and they can make sure it's going to be an appropriate hospice referral.
And furthermore, I think what we should do there, Daniel, is that an email should be sent to Nina, yourself, and myself.
Yeah.
And that way we can make sure that the patient's being followed.
Yes, absolutely.
Oh, I just want to say kudos to the hospice team. This is amazing. I have to let you know that I've had 2 family members under hospice in the last year, and they are amazing service. It's such a broad a definition of criteria that, how hospice patients can fit. So you might think out of the box. And also, I want to also encourage the MSWs to be on the case because a lot of times they can have these conversations. I think, quite frankly, it's difficult for our clinicians to have that initial conversation with the families. If you're finding that's the case and you feel that the patient is appropriate for hospice, I would suggest that you do an MSW evaluation because they are the experts in terms of having conversations, these hard conversations with patients and their families. And this can be a very difficult time. A lot of times our patients, families, or the patient themselves may be in denial. It kind of helps to guide the decision making and maybe making more of an appropriate choice than to continue, life and try to expect things that really are not feasible to something that's more along the lines of support to end of life issues. So I just want to put that out there, and they're an amazing group. Are there any further questions at this time?
An additional comment, Tanya. One thing that we don't want to do is to have the hospice team come and speak to the patient without informing the patient and family.
Absolutely.
That's happened a couple of times, and you can imagine getting a call and saying, "Hey, by the way, we're hospice team because we hear that you're not doing very well." It can be a scary conversation for patients and families who have not been prepared. So, if a patient family speaks to you about potentially getting a hospice consult, then absolutely go and follow that process. If you feel that the patient may be hospice eligible, what I recommend is that you reach out to Daniel and myself first. Let's talk about the case, and then that will decide what we do as far as next steps go. If they say, "Yeah, I think this is eligible," then we can go ahead and proceed with the process. You as the clinician that's making the recommendation, you speak to the family first and the patient, prepare them for the conversation, and then we move our hospice team over.
Yeah, and we'll be even willing to, do a joint visit. Let's say, the patient feels super comfortable with the clinician and, they want to do a joint visit. We'll be more than happy to, after reviewing, come in and do a joint visit as well in the home.
Yeah, at the end of the day, guys, hospice is for comfort care. It's to minimize suffering. It's to closely manage symptoms that we in home health just cannot do. So if the patient needs it, please start thinking about referring to hospice.
Okay.
I have a quick question about this. For Kaiser patients, if there's a patient that we think is headed towards hospice, sometimes family just wants information, and I usually reach out to the PCP at Kaiser to facilitate a consult, but I'm just wondering if there's a pathway. If for Kaiser patients, we should always go through Kaiser first.
Yeah, it has to go that way. That's
Okay.
the pathway.
All right, just making sure.
Mm-hmm. And the Kaiser patients, if they choose ACE Home Health Hospice, ACE Hospice Services, they can go with our company, even though they're a Kaiser member. And many of them have asked for our services as a result of home health being involved.
Well, I've had that conversation with a couple patients where the family was like, "Well, we want to go through you," and I was like, "Well, let's go through your doctor," and then you can make the request that way, but not just wanting to make sure with Kaiser we're going through them first.
That's the appropriate pathway. Thank you, Shireen, for sharing.
Sure.
Tanya, I think we need to move on because we have a special presenter that's only available until 10 o'clock. Yeah.
Thank you, Daniel and Nina. We appreciate the presentation.
Thanks, guys.
Thank you. Bye.
Bye-bye.
Okay. Joey, do you want to give a quick update or do you want to go to the access training?
Let's go to the access training and then we'll summarize afterwards.
Okay, very good. Akila, are you on the line at this point?
I am.
Okay. You want to make an introduction?
Yeah, so everyone, today we have on with us our rep from Access. Her name is Kara, and she has agreed to join us today to give us some OASIS, value-based purchasing training, or value-based purchasing education so that you guys can understand why the way that we score the OASIS is so crucial in current times. So Kara, I don't know if you are there.
I'm here.
All right. Thank you. Take it away.
All right. Well, hello, everybody. Good morning. Just a little background for myself. I am currently an account manager with Access, and my history is I have had 18 years experience in home health. I'm an RN by trade and just looking to help you guys however I can. You know, Medicare, it's an ever changing environment. So we need to adjust and really focus on value based purchasing, quality outcomes. So I wanted to take a little bit of your time today to review a few things. I'm going to attempt to share my screen. And if you will just let me know when you can see my screen.
We can see it.
Perfect. So this is our value-based purchasing dashboard. The reason this is important, because one, it measures quality measures, which is what we get scored on as far as, you know, star measures, what are our outcomes, are we improving, are we not improving, but also with value-based purchasing, because Medicare has decided they're looking at everything now. We have to show improvement, or otherwise, you know, Medicare says, you know, if we can't show improvement in the home, then why are we out there? So I worked with Joey and Akila on some of these outcome measures. And one particular area that I wanted to look at, me personally, I like to start with ambulation, just because I feel like that sets the stage for all of our functional components of an OASIS. So you can see here, we measure this quarter over quarter. This is going to be the percentage of the patients that showed improvement during that quarter. And when you're looking at quality-based outcomes, your star measures, and value-based purchasing, we're graded on this. We need to show that we are making improvements on these patients, or one, we get a bad grade, and two, we don't see any kind of reward, if you will, from value-based purchasing. So I did go ahead and drill down on ambulation for this quarter. And just to show you guys, this is where this data goes. I've just exported it to a spreadsheet. And what I'm specifically looking for, I drilled this down to all zeros, ones, and twos for ambulation. The reason why I do that is because those are going to be scores that don't leave us much room for improvement. You know, a 0 is completely independent. 1 is independent with the use of an assistive device. And then 2 is the patient needs supervision. And so,
Kara, I'm sorry.
yes.
Do you mean to show the screen that I have up right now is still the Access website, value-based purchasing?
Oh, pardon me, Joey. I'm not
Right.
used to using Zoom. Let me do a new share here. All right.
There we go.
There we go. So again, what I did is I just set the filters, because what I want to look at for ambulation is I want to see the patients that we scored 0, 1, or 2. Reason being, we're not leaving ourselves room for much improvement. And so I really want to drill down on these to go back and look at those charts, and let's just paint the picture. Let's go back and see, did we truly answer this correctly on Start of Care? Or, you know, should we have considered a little bit of a lower score to allow ourselves for improvement? So let me go ahead. Bear with me, guys. Let me get, there we go. All right. So what I wanted to do today, I pulled up a chart that the ambulation score was a 0. What does that mean to us? That pretty much means the patient is independent. We want to look at that because, one, Medicare really wants to make sure that we're out there for a reason. We need to be sure that we can capture these improvements, and but we need to make sure that we're scoring them correctly on start of care. So what I wanted to do today was just do a quick chart audit on this particular patient. This particular patient was scored a 0 for ambulation. And so let's just go through the chart. What I want to do for everyone on the call today is paint the picture of this patient. Who is this patient that we're going to see? And just, be mindful that all the documentation here is from the clinician that was in the home. They were with the patient, and this is what they documented. So the first thing here, we can see that they are a Medicare patient. We can see that the discipline completing the OASIS assessment is an RN. And forgive me if I make you dizzy, because we will be going fairly quickly through some of this. The first thing here is episode timing. So this is one thing that Medicare looks at is this a patient that is new to home health, or are these subsequent episodes with home health? So when you see an episode timing of early, that means it's the first time they've had home health in a while. We can see vital signs here. Everything looks good. But then you can see our M1000 here. This was a hospitalized patient. So when you're looking at an early timing coming from a facility, you need to keep in mind this is going to be the sickest you've ever seen this patient. They were just hospitalized, and we're getting them post-acutely, and we're charged with progressing them to hopefully become independent, or as independent as they can be. Second thing that I want to look at is diagnoses. Let's continue to paint the picture of this patient. This is a primarily COPD patient. They have CHF, pulmonary hypertension, they have valve disorders, they have alcohol dependence, they're on anticoagulants, AFib. You can see the diagnoses, they're pretty severe. We have cardiac and respiratory, and someone who is dependent on alcohol. So let's keep going. We can see they are dependent on oxygen. They've had recent pneumonia, and they're high risk for infection. So let's move to M1033, and let's talk about a few of these. And I encourage questions at any time, but we have documented that this patient takes 5 or more medications. They're exhausted, which we would expect from a COPD patient. However, let's look at these other ones, and let's kind of talk about this. So history of falls. I know we have a lot of therapists on this call. What identifies a fall? I know from an RN standpoint, I look through rose-colored glasses. I'm like, they have to trip and fall down to the ground in order for it to be considered a fall. But really, it's just a change in surface level. So when you're getting your patient up and say you're doing your tug, If they have to, use their walker and they try and try and try to get up off of the sofa, but they keep falling back into the sofa, that's considered a fall. Are we accurately capturing that? Because the point of this, we need to minimize rehospitalization. So we need to identify it on the forefront. So unintentional weight loss, it's a COPD patient. We know that COPDers, they burn a lot of calories because they just struggle to breathe. They utilize a lot of calories strictly to breathe. Is this the first time that they've been hospitalized in the past 6 months? Did they utilize the ER on this hospitalization? COPDers, we know they're anxious. They kind of, get a little nervous and maybe utilize the ER as a support blanket. Did we really capture that or not? Decline in mental, emotional, behavioral status. Okay. Again, it's a COPD patient. Typically, they're anxious. They were just hospitalized for pneumonia. Did that increase their anxiety? Is it going to affect their function? I don't know, but there's a high likelihood that it could. And then reported or observed difficulty complying with medical instruction. They were just hospitalized. Did they have med changes? Are they comfortable with that? Or do we need to educate them on that? Do we need to ensure that they know when to take those medications, how to take those medications, and what those side effects are? Or do they need our assistance? So really looking at that M1033 to ensure that we are capturing that true risk for hospitalization. So any questions on M1033? We'll keep going. So this clinician has said that there is a fair opportunity this patient's going to get better. It's not good. It's not excellent. These are chronic diseases. We're going to do the best we can. Let's keep going. They're on an anticoagulant, which we identified in diagnoses, and they're on O2, which poses its own fall risk, right, with O2 tubing. They're slow on position changes. They require DME that needs electrical safety, probably the O2 concentrator. They're at risk for falls. They may live in a cluttered environment. They're not safe. They're not safe in their ADLs. Infection control, they just had pneumonia. We need to make sure that that does not recur. They need support during transfer and ambulation, and they use assistive devices. So hearing and vision, doesn't look like we see any real effects with that. Integumentary, we haven't identified any issues with that. So respiratory, the patient's dyspneic. They use O2. We haven't identified any safety risk, probably a long-term O2 user. We have said that they get dyspneic with moderate exertion. So anybody on the call, would you like to maybe give me some feedback on what a 4 on dyspnea would truly mean if they are dyspneic at rest? So really what this is going to mean, if they require O2 support during the night when they're in bed, they're dyspneic at rest. This one, it's hard to gauge on start of care. which we did, what did we say on this one? Moderate exertion. So really, they start getting dressed, they get short of breath. From a nursing and therapy standpoint, what we want to do is educate on energy conservation. Can we get them to the point where they don't need that O2 all the time? They're okay to pull that cannula off, go to the bathroom, come back and put it back on. Okay. But this patient right now, they're probably O2 dependent 24/7. And it was probably better scored as a 4.
So, Kara, just for clarification, if you're saying that if someone's on O2 24/7, then the automatic answer at 4 is, automatic answer for M1400 is 4?
For OASIS purposes, yes, sir, because they require oxygen when they're at rest in bed.
Okay.
All right, so let's go to cardiac
Just a sec.
status.
I got a question or an observation, but for this patient, it's intermittent use. It's not, according to the thingy you take, it's intermittent. It's not all the time. So would that still be a 4?
If they wear their oxygen at night, and that's all Medicare is asking. That's all OASIS is asking. At rest, when they're asleep, they're resting. If they need to use it at night, then that would be at rest.
Is there anyone, has it been documented that they wear the O2 at night?
Hello, this is Mary. Hi.
Hey, Mary.
Yes.
Mary.
For this one, some people just like to wear it at night for comfort. Like they're not probably dyspnea, but they just want it to. It's still a 4 if that's the reason why they're wearing it at nighttime.
Well, so when we're looking just from an OASIS scoring standpoint, we're looking to capture accurate information on start of care because we need to show improvement. So for this patient, if they just came home from the hospital, diagnosed with pneumonia, and they wear it at night because they feel like they need it, then yes, they require it at rest. However, our goal, because we know this patient will probably always and forever need oxygen, right? So what we need to do is move them from a 4 to a 2 on discharge, where they don't feel dependent on that at night, where they're comfortable wearing their oxygen and they still need it, but they don't need it all the time, or they don't need it for comfort. So if we can score them a 4 at start of care and then a 2 on discharge, we're showing that improvement because that's what we did. We made them out, we went out there, made them more comfortable, and they don't rely on it as much as they did at start of care.
I just have a quick question. I don't know if this is what Mary was asking. So in this case, it would be a 4. However, given a patient that chooses to wear it at night, despite no physiological needs for it, or any O2 sats dropping, would that not be a 4 then? So they're saying they report they wear it at night, but in the session, there's no O2 sats dropping or any indication of that needed.
Correct. The patient, even we have to take cognition and emotional behavioral stuff into, we have to think about that when we're scoring these OASIS. Any behavioral, emotional, cognitive stuff is going to affect function, including dyspnea. She's likely anxious, or he's likely anxious and feels like he needs it at night.
Kara,
yes.
What about those patients who are on CPAPs or BiPAPs? Would they also need to be scored at a 4?
I would have to clarify that. Okay, Chris. Yeah, I would have to look at OASIS guidance on that one.
So for most patients who wear CPAP or BiPAP, they do wear it at night. So that may constitute a 4.
Right.
But then that would never improve, correct?
It's yes.
Oh, if CPAP, like if they're on CPAP, that would never improve. That's not really
right. I would need to clarify that with the Medicare guidelines. Like I said, we can I can look at that and provide some clarification. Definitely.
I was going to say, I just wanted to comment that some of those CPAPs are connected to oxygen.
Right.
Yeah.
So we would need to get clarification on Medicare guidance on exactly what they're looking for. Is it just O2 from concentrator, or would CPAP or BiPAP qualify for that? All right, going on to cardiac status. We can see from diagnoses we identified the patient does have CHF. They have some valvular disorders. However, looks like everything is okay. That's under control for now. They are not incontinent of bowel or bladder. They have not been treated for a UTI, nor do they have a catheter. So let's look at behavioral status. So everything documented here, this patient is alert and oriented ×3. There's no additional behavioral symptoms identified. So behavior, we're good. What we'll do is we'll go look at the med list after this. Just because I would anticipate this patient would have some anxiety, but maybe not. So cognitively intact. Functional status, no problems identified. Fall risk assessment. However, they are at high risk for falls. They've fallen within the past 3 months. However, going back to M1033, remember we documented that there were no falls. So a little bit of contradiction there. So let's look at functional status. And let's go ahead, we'll look at everything, but then we're going to drill down on ambulation. So for this particular patient, we have scored them 1s on self-care. Bathing, we gave them a 2. They're able to bathe in the tub or shower with intermittent assistance of another person, or for intermittent supervision or encouragement or reminders. So they need help here. We've identified that. Yes, Rosanna.
Okay, hi. Sorry, just a quick question. I think it was M1700, the behavioral. I just wanted to make sure, because I know that I feel like QA sent something back to me. But if I find that the patient, you just passed it actually.
Yep. 1700.
Oh, I'm sorry. Maybe it's. I'm sorry. Can you scroll down? I forgot what it's.
Yes.
It's the behavioral one. Almost there.
1740.
This one, cognitive 1740. I'm so sorry. Yeah.
Okay.
On this one, if I find that a patient is, not using their walker safely, or leaving it aside, or or let's say not following their spinal precautions that the doctor's saying, I will mark 2 on this. Because because sometimes, when I read this question, cognitive behavioral psychiatrics, I'm thinking someone who, it has cognition deficits.
Correct.
As I come to fill this out, I realize, gosh, this person is unsafe because they're not doing what they're supposed to. So I usually mark 2. I just remember I got it sent back and they were like, oh, they don't have any cognition stuff, but that's okay to mark 2, right? If I feel like they're unsafe. Okay. All right.
If they require the use of an assistive device.
Okay.
And they fail to use it,
Mm-hmm.
that is impaired decision making.
Okay. Yeah.
They know better. They don't mean to, right? It's not intentional. They just forget.
Yeah.
Okay. But what else does
Rosanna,
that tell us?
that's a really good point, because I mean, you can even go further. If they're a fall risk, and they've had history of falls, and they try to get up by themselves, that's also a 2.
Exactly. So I usually utilize that a lot because it says jeopardizes safety through actions. And I thought, well, yeah, they're not educated enough. So by the time discharged, they will be. So they will be 7, right? Yeah. Okay. I just wanted to make sure I was doing that right.
No, that is correct. And what else that is going to impact, Rosanna, is in 1745.
Right. Exactly.
Because this was a hard one for me as an RN, because you read this question, any physical, verbal, or other disruptive, dangerous symptoms that are injurious to self or others, that sounds horrible, right?
Yeah.
However, or jeopardizes personal safety. If they forget their walker at least once a day, it's at least daily.
Exactly. Yep.
Because that is how frequent they're displaying this behavior up here. Great question. I love it.
Thank you.
So that goes back to, let's go back to, okay, so we stop with bathing. We have said this patient transfers independently. They can transfer or go to the bathroom independently. They can transfer out of bed independently, and they can walk independently. However, we just said up above at bathing that they're not independent. So when you're looking at ambulation, let's just talk this through. We've already documented that the patient is short of breath. Do they not? I mean, how far is the bathroom from the living room where they're sitting watching The Price is Right? Right? They got to get up, walk to the bath. Do they need to stop in between? Do they have that walker and they're forgetting to use it? And another thing to consider, even though, guys, they may not have a walker, they may not have any DME in that home. However, if they would be safer ambulating with a walker and having someone in that home to remind them to use that walker, they are at the very least a 3. Okay? Remember, supervision, it doesn't necessarily mean you have to touch the patient. It doesn't necessarily mean you have to even say anything. But if it would be safer if you were standing in the corner of that room with that patient, just in case they needed that reminder or that assistance, then they need supervision. They require it. Because now that we've answered all these 0, we've left ourselves no room for improvement whatsoever. And I like to utilize ambulation as an example because this is kind of your baseline. Whatever you score them here affects everything else because they have to ambulate to get there. They have to ambulate to get to the bathroom. They have to ambulate to their closet. They have to ambulate to the kitchen to go eat. Oral meds. Where are they located? Are they in a pill planner? Okay. Do they keep them right there by the recliner, or do they have to get up and go get them? So, that's the big thing with functional scoring. All of this kind of has to mesh together. You can't be a 2 in one area, but then a 0 in everything else, because it all affects itself. Does that make sense?
Yes.
Yeah,
I also
just,
have
I'm sorry, Matt, go ahead.
You can go ahead.
You're a lot smarter than I am, so go ahead, Matt.
I was going to ask too, just for confirmation. So memory care unit patient, Alzheimer's, dementia, they don't typically walk with the device. They're walking,
Nope.
fairly stable.
Walkie-talkie, right?
What's that?
They're walkie-talkie. Yeah.
Right. However, they're typically under supervision on that floor. They're not able to leave the floor due to potential issues, just cognition issues, safety issues.
Correct.
Would you then mark them as a 3 as well, correct?
Yes.
Okay.
Because what's going to prevent that patient from walking out that locked unit onto the street and getting hit by a bus? They don't know. They don't know. They require supervision for everything. But now that you bring that up, because that's a great example that I love to use, let's go back up to your M1700s. So dementia patients, okay? They're not going to be alert and oriented. They're totally dependent, right? I mean, they're essentially infantile. They need direction for everything. Even though they're up walking, they're talking, their speech is nonsensical most of the time. They have no idea where they're going. They're completely dependent, okay? And so we need to be sure that we're capturing that. Whoops. Lost my screen. And back down to this M1745. Frequency of disruptive behaviors. It's at least daily. Be mindful from a quality measure standpoint, from a value-based purchasing standpoint. Medicare does not expect those patients to improve. It's unrealistic. We cannot educate them. We might be able to get them stronger. However, it's their cognition that will forever be their hindrance. And so those particular patients, they're thrown out of this scoring. It's kind of unfair, right? Because we can't really improve those patients. That's why we need to be sure that we're looking at this cognitive area and be sure that we're capturing that impaired decision making and correlating that with our function. If that makes sense, Matt. Does that help?
Yeah, it does.
Oh yeah, I just wanted to confirm that I was correct in that.
Yep,
judging
you
that
are.
for. Okay.
Kara, if a patient has or is a fall risk, wouldn't you automatically score them as at least a 3 on 1860? Yeah.
Yes, sir. Yep.
Even though they are walking on their own, that just speaks to the judgment part.
Correct.
Yeah. Okay.
They're still at risk. They're still at risk whether they're using an assistive device and they live alone. They're still at risk. We're capturing that risk. And what we're trying to do is make them safer. We need to make them safer in their environment. So let's go ahead and look at this narrative and we'll kind of wrap this up. So in order therapy on this patient, just nursing. Just keep going. Okay. Let's just look at this narrative. So started care confirmed on a 72-year-old male. CHF, he has AFib, encephalopathy, probably from alcohol. Again, guys, is alcohol going to impair judgment? Yes. He presented to the ER, so there's one ER visit. We need to be sure, did he have another one within the past 6 months? So he was hospitalized with COPD. He's alert and oriented ×4. Probably not when he's been drinking quite a bit, but who knows? He's on 1 liter of oxygen. He doesn't complain of short of breath. However, we can see that he's short of breath. He doesn't complain of pain. He's up ambulating without assistive device. Okay. So it looks like maybe he had COVID-19 pneumonia. That's what I'm thinking. So we documented that he had assistive devices, but let's go see what exactly he had. So the patient wants to know how to take his meds, what he needs to eat, kind of exercises he needs to do, how does he manage his symptoms. However, back on 1033, we said that he's perfectly fine taking care of himself. Let's see. So just oxygen. We didn't document any other DME. And it looks like he does have somebody that helps him, but probably otherwise lives alone. So that's it. Any questions?
Yeah, Kara, I think what's going to happen here is that we're going to have to invite you back another time to speak directly to those who are doing starter cares and who are doing Oasis, discharges, research, and so on, to do a deeper dive on some of these items that we need help scoring.
Sure.
This is very, very revealing. I learned a lot today, as I did the last time we spoke. So this is very valuable. We thank you for coming.
Absolutely. All right. I appreciate it. I hope everybody has a wonderful day, and we will talk soon.
Thanks, Kara.
All right. Bye, guys.
Thank you so much.
And guys, I should have added it in my introduction, but I was multitasking and thus my brain was not working. So Kara is a nurse. She's worked in home health. She was the DPCS for an agency for many, many years. And through her experience and certification, she's become somewhat of an Oasis expert. So we'll be, not letting what she's saying go through one ear and out the other, taking the education she's providing and implementing it into how you're scoring your Oasises, is why we brought her on and want her to continue to help with education. So just so you know.
Thank you. We appreciate her expertise, and we'll move on at this time. And Joey, would you like to give the company update, and we'll finish out the meeting for the rest of the remaining hour?
Yeah, just real quick, after I do that, Tanya, I think I'm going to go straight into the clinical outcomes improvement initiative, if that's okay with you. Okay. So quick thing when it comes to the company update, as far as hospice goes, you heard two of our leaders on the hospice team. They're doing great. This is one of those little news is good news. We're still in the midst of the growth in hospice. They're doing about 100. They're processing about 100 charts a month, which is a lot. That they're admitting over 30. I think last month was 35 patients, but discharging about 25 to 30. So there's a lot of work, good work that's being done downstairs. As far as home health goes, our current census as of yesterday was 601. We have as far as Medicare and Medicare Advantage, our number is right at 300. Kaiser's 150, and then the other private insurances are equals about 150 as well. We're growing. And to that point, I wanted to go, hold on a second. How come this is not, I'm trying to share my screen. Hold on a second. I want to go straight into, can you guys see this?
Yes.
Okay, awesome. All right. So essentially the speakers that we've had this morning, the introductions, have been a really good setup for the main need of our meeting today. So you guys know our census is up. We've hired, onboarded, trained, preceptored more people than in the history of the company, and I'm talking clinical and administrative staff. I think about 3 weeks ago, I counted, we are over 150 employees between home health and hospice. Never have come close to that. We've expanded our service area. You guys know this. We're going all the way down now to Gilroy and Morgan Hill. And we continue to focus on, certain key metrics, timely initiation of care and great patient care. There is a sense of stability. I was speaking to Tanya, Akila, Matt, Chris. Yeah, we meet every Tuesday morning. We can kind of breathe a little bit right now, because over the last 4 or 5 months, we've been going at a pretty breakneck speed. It's been pretty intense, but we can kind of breathe right now. The thing is, I wish we could get graded on the things that we've accomplished thus far, in terms of CMS. But the reality is we're not. We're graded on data. I know, and you guys heard earlier, Tanya's mentioned some clinicians that have had patients speak about them, and that happens on a regular, guys. That happens. So we know we're providing great care. But the reality is that's not how we're measured. We're measured by certain data. And I'm glad that Kara talked about this earlier. When it comes to home health value-based purchasing, these are the 12 items that we're graded on. Kara drilled down a little bit on it, but these are the 12 items. And I will tell you guys, I cropped out, some of the information here because I didn't want to show you our scores. We, as an agency, are compared to cohorts, which means agencies our size deals with a certain population from Medicare and private insurances, and we're not scoring as well as we want to. So our focus has to shift now from growth to showing that we're providing the great care that I know we are. Okay. Another data that you guys should know. So, if you drill down to claims-based measures, we're graded also on acute care hospitalization and emergency department use without hospitalization. We're graded on that. We're graded on patient surveys and what patients are saying about us. We already talked a little bit about dyspnea, but management of oral meds. I know Tanya has drilled this down over and over again during orientation. You see now change in mobility, self-care. That's really important as well. But I want to talk a little bit about hospitalization. This is taken directly out of Access. Let me explain a little bit about this graph. The third line from the top, the brown line, where it says 13.11%. You guys should know that from Q4 of 2022 to Q3, which we're in right now, we are seeing patients with higher hospitalization risks. That means that we're dealing with sicker people in home health. At the same time, you guys also know that our rehospitalization rate, which is the red line at the very top, That's our rehospitalization rate combined. 2 weeks, 30 days, 60 days, 180 days. It's 21%. The line below that is the gray line. That is the rehospitalization within 60 days. That's a 16.81%. Okay. That is our overall agency number when it comes to hospitalization rates. What we also know is Kaiser Oakland, dealing with a similar population, patients that we're seeing for Kaiser Oakland is at 14.9%. So it's a comparison of 21% to 14.9%. Kaiser Martinez, understandably so, is 9.4%. And I say that because we get a lot of orthopedic cases out of Kaiser Martinez. So we expect it to be a little lower. So what I'm saying here is that somehow our Kaiser patients are not going into the hospital as often as our overall agency number. All right, so we'll move on to the next piece of information that I want to share with you guys. ALOS stands for average length of stay. It essentially is the number of days that each patient that we admit on average will stay on our service. When we pulled out the Medicare population, the ALOS is 51 days. Utilization average stands for the number of visits that we do per admission. And the average for Medicare patients, we do about 31 visits per patient, per admission. In comparison, when we combine all the entire census from every payer, the ALOS is 47 days, which is a little less than Medicare. The visit admission or the utilization number is 25.72, so it's less. Now I want you to look at the last two items here, Kaiser Oakland and Kaiser Martinez. Their ALOS is significantly less, and the number of visits that we do per admission is from 18 to 19, depending on which branch. So I'm going to go back to the previous slide. The patients with the Kaiser Oakland, Kaiser Martinez goes into the hospital less often, and yet we see them for less amount of time and less visits. So the old thought that, we need to continue seeing patients more and longer to get them better, according to the data, and this is data that we gathered over the past year, that's not true. So we actually had a conversation when we looked at this number over the last couple of weeks. We called key leaders at Kaiser Oakland, people that we know, we've worked with before in the past, people that we respect. They're part of their Kaiser's QA team, Kaiser QA and QI team. And we asked them, what is it that you guys do, that you make us do, that works? We thought, when I first called them, I thought that they were using some clinical pathways. They were dictating what happens on every visit from the start of care to the discharge. They said they tried that, but it actually didn't work. It made their numbers get worse. What they said are these quick key points that I pointed out here. They focus on getting the admissions done within 48 hours. That's number one. Second, they focus on getting the assessments by other disciplines that are required on that case done within 5 days. They get them out there sooner. Then they all front load their visits because they feel if patients have been discharged from the hospital, the more that we care for them at the beginning, the more stable they get. The next one was a surprise for me. They said they get MSWs out on most of their cases. And the reason why is the MSWs are very effective in making sure that the patient has the proper caregiver or caregiver support in the home and to provide community resources. I asked them to explain that a little bit. They said, well, caregivers are there to make sure that, MSWs are there to make sure that there are caregivers to follow up on the care plans that you guys are implementing. Because if you're not teaching anyone other than the patient on what to do to prevent themselves from getting worse, clinically worse, then there's not going to be much follow through after you discharge. But if you make sure there's someone there to follow up on it on your care plans, the likelihood of that patient going back into the hospital becomes less. That was an eye opener for me. I mean, we've known that MSW services for ACE has been underutilized, but not to the point that Kaiser is suggesting. They also do a lot of case conferences on their patients. In fact, every 2 weeks, they have a case conference on every one of their patients, and they're very fast. We were told it takes them about an hour and a half to go through about 150 to 200 patients, because there are only 5 items that they talk about. And this is driven by a physician, actually a director of home health. If a clinician starts talking and starts giving a report outside of those 5 points, they shut them down. They don't want to hear it. They just want to focus on those 5 points. And we'll talk about that a little later. And the tighter case management, that's part of the case conferences. And then, they focus the visits, the interventions, so that we can discharge the patient safely. So that's what we were told directly from the horse's mouth. This is what we do. It's a philosophy. So we need to get our numbers better to prove that we're providing the service that we know that we are. We just don't have the data. We just don't have the numbers to support it right now. So what we decided was to create this clinical outcome improvement program. We're going to modify a Kaiser type model of case management. You know how Kaiser has been in the past. 5 months ago was 70 to 80% of our referrals. Obviously, it's not based on the numbers that I gave you guys earlier, but we know what Kaiser does works. And one of the things that they do, and this was very irritating to us when Tanya, Akila, myself first stepped into our roles, when they told us you can only have 4 visits at the beginning and then you have to justify additional visits after that. Really upset us. But it's their way of case managing, their patients. We're not going to be that strict. We are going to adopt a Kaiser model that will fit us. So the auth process will be something that we implement with all cases at this point. And Akila will talk a little bit more about that a little later. We will audit regularly 10% of our charts. And we're not only going to follow the 11-12 value-based purchasing data points, but other points that we need to focus on. We're going to start having team case conferences. Not every patient will be discussed. We'll focus more on the very high risk ones to prevent the hospitalizations from happening. And we're going to increase our MSW referrals. I don't know if Tanya mentioned earlier, but over the last probably 3-4 weeks, we have hired and are onboarding quite a few MSWs in preparation for what we're about to do. And there's a clinical assistant program that's happening right now in a pilot phase. And Akila will learn more. I will speak to you guys more about that. But there are several RNs and PTs that are already being assisted by the CAP. And we're going to roll this out when we vet it and we create the processes a little bit more. But we're doing it to make sure that you guys are supported in the things that we're trying to accomplish as a company. It should be clear that the goals for this program is to improve the documentation of our patient outcomes, improve scores of the VBP, lower the rehospitalization rate. We want our patient outcomes to get better and to keep them out of the hospital. Those patient survey scores, we've got to improve on that. I know we preached on this point many times before in the past, but we really are going to be focused on it now. And lastly, equally as important, we want to continue reducing your clinician workload. We know that we're asking more from you, and that's why we're hiring more administrative staff to support you. And that's part of the CAP program. So next steps, pretty simple. It's what I already talked about. You'll get more information on this program over the next couple of weeks, and we're going to start implementing them over the next 3-4 weeks. One thing that you guys should know, the value-based purchasing program, it's in 2 parts. This year, they're collecting data on how we're performing as an agency. In 2025, they will then put us in under 3 tiers. The first tier is that it won't, and this speaks to the reimbursement part of things, the business part of things. If we're put in the first tier, that means our reimbursement stays the same. If we don't score very well, they will take out 5% of our reimbursement. That's significant for agency our size. If we do well, then we get up to 5% increase in our reimbursement. And obviously that's what we're shooting for. We want to be able to push, that increase back to you guys, back to the people who are doing the great work out there. So please help us. This is a big lift that we're about to undergo, and we're going to need everyone's help for us to be successful in this type of growth. Any questions?
You're silent, pretty silent out there.
I know. Cricket.
I hope that doesn't mean that you're traumatized. It's going to be actually a positive way of moving forward. And I just want to say that I support Joey and the presentation. Myself, as well as Akila and Joey, have been in development of the clinical outcomes initiative. And we've seen it work, not only at Kaiser, but generally, I'll just say when I've done research on the home health outcomes, the clinical outcomes and the quality measures, is that they adopt the same type of program and the process that we're doing here now at ACE. And it shows that it's much more effective, that the outcomes are much higher. And that's where we're trying to grow to. In fact, I know Joey didn't mention our star ratings scores, but they've dropped. And the reason why they've dropped, it's not that you're not giving good care, is because of the documentation. So all of the presenters, especially in terms of how we address the OASIS, affects those outcomes, and it affects our scores. And we want our scores to really reflect the quality of care that we know that you are giving and our patients are receiving. So I know this may seem like a lot to digest, but it's really for the better good. So I'm looking forward to the implementation of these programs. And with that, I'm going to turn it over to Akila, and then Joy, you'll follow that. Thank you.
I do have something that I would like to say, if it's possible. This is
Teresa. Go ahead.
So I have a lot of patients that I have called and I have been to their homes and they just don't return phone calls. If any of you who are visiting patients, give me a call when you're there. I would really appreciate, because I do a lot of drive-ins and they just don't respond to, I left notes on their doors. So please call me if you are with the patient so I can schedule my appointments with them.
Oh, that's an excellent suggestion, Teresa, and that often works. And I've done even one step further. I've made it almost like the joint visit at the end. So when I'm finishing up my visit for nursing, then MSW just follows me and tags me on the end. And that way we can be sure that they do get their evals done and done in a timely manner. Thank you for that suggestion.
Belita, you were going to say something?
Yes, Joey. I just wanted to know. Yeah, I think those are really good inputs, and I think that would be very helpful with the company. So, when will that take effect?
We're working on a start date. I believe it's going to be in October.
Got it. So, so having said that, so there will be more like a consistent. Do we have like a consistent time frame when it comes to like case conference? So in that way, we can kind of plan ahead.
Yes.
We'll be developing that and sending that out to you ahead of time so that you can plan around your visits.
Yep.
Most definitely. Just like we have the face-to-face normally on the third or fourth Thursday of the month, you'll have a scheduled day when we'll do that weekly case conference so you can schedule around that and be able to, effectively see your patients.
Got it. And then also one last question. I know everybody's. I hope I'm not holding them up. You did mention about like front loading the visits and then getting it more like a shorter time frame. And again, depending on the assessment. So would it be more feasible to kind of get like the first episode rather than doing a recertification and address all the needs like on the first episode?
That's the goal. That's the goal, Polita. We try to address all the issues up front. And if needed, much like Kaiser, if needed, if we need more visits, then we do that.
Got it.
Yeah.
Okay.
So
Thank
that's
you.
the reason why we're encouraging people to do front loading as well as to add the MSW eval as a part of the episode so that we get the resourcing that the patient needs, caregiving assistance, and actually part of the discharge planning process to make sure that they're stabilized within that first episode. And we found that less visits and shorter duration has proved better outcomes. So, Akila, you want to take it away?
Sure. And just to follow up on that, so everything that Tanya and Zoe said is accurate, that it is proven that it not only improves your outcomes, but it also helps to decrease your hospitalization rate. But on the flip side of that, we don't want anyone, we want to make sure we're discharging safely, because on the flip side of it is that we are deemed if that patient goes back to the hospital within 30 days after discharge, right? So we still want to make sure that we're thinking about that when you're discharging is this patient safe? Do they have all the resources needed for them? Is there anything else that home health needs to provide to them to make sure that they maintain being safe and have the resources they need or the care they need to not go back into the hospital after I discharge? And all of these things will be discussed with this new our outcome initiative, which is a work in progress, right? So what I'm showing you now are things that we're still editing and we're still trying to figure out, put all the pieces together. So this may change by the time it actually gets rolled out. But essentially what this program is, the purpose is to produce improved quality care, which we know that we're providing. However, we can always be better, right? There's always room for improvement for all clinicians, for the agency, for everything. And
Akila,
then,
I'm sorry. I don't know if are people hearing background noise with Akila's presentation, or maybe it's just me. I'm not certain.
No, there's a lot.
I hear it.
Yeah, I hear it.
Okay, go ahead. Then I'll just deal with it. No worries.
Okay, well, hold on. Is this better?
No, also hear background noise as well.
Okay, thank you for now. Okay, is that better?
Yeah, that's better. Thank you.
Okay. Where was I? So improved quality care that is shown in our outcome data. And that data is the value-based purchasing that Joey was talking about, where there are key items, and a lot of those items that Kara talked about today are the items under value-based purchasing, and that we're being scored on, and that can potentially, if we do not show improvement, can be that 6% either increase or decrease as Joey was talking about. But there are other things that our data is used for. So our star rating that Tanya mentioned, where you can have a maximum of 5 stars and as little as, obviously no stars. We were at 4 stars. We're now at 3.5. So again, there's room for improvement, which all of these things we're implementing should help with that improvement. So the qualifiers for this program would be Medicare, Medicare Advantage that pay as episodic, and Medi-Cal patients to start with. As Joey said, we do want to implement this for all patients, but to start, we'll start with these insurance payers. And then there's if they fall under category A or B. So have they been rehospitalized or do they have these diagnoses listed here? Again, this can change by the time we do rollout, but this is what we have thus far. And then we have a set utilization, like Kaiser, except we're giving more. Kaiser typically gives 3. A set utilization at start of care where patients get a set amount of visits that are authorized. So 6 visits for RNPT, 4 visits for OT, 2 visits for ST, 3 visits for social work. And then the home health aid frequency should match either the OT or the MSW, because as we've talked about in the past, if we're assigning a home health aid, there should be either an MSW assigned that's helping the patients with caregiver obtaining a caregiver, or there's OT that's doing caregiver training. So what we have thus far is that what we're thinking the procedure would be is that we implement an authorization forms, which I'll show you guys in just a moment. And that's what is submitted to request more visits from the clinician for that patient. The QA coordinators will be involved to assist the clinicians. Between the QA coordinators and the clinical assistants will be involved in assisting the clinicians in completing that required form. And then the authorization, obviously, form is required to accept more visits outside of what you're automatically approved for utilization at start of care. And then we'll also use the auth form that's being completed as a guide for our case conference. So Joey had talked about, I think it was Kaiser that had 5 strict questions, and they didn't derail from those questions so that case conference could run smoothly and quickly, and all the patients could get out. They were able to get through all those patients. So this would be the updated authorization form for non-Kaiser patients. And again, we're going to work out how we assist all the clinicians in differentiating between and not getting confused between this internal form and the Kaiser form, and assisting you guys with reminders for filling it out. But much of the same information: the clinician name, request date, patient name, start of care date, frequency. What's new is utilization to date, which will be filled out by either the clinical assistant or QA coordinator. The goal attainment rate, also filled out by the clinical assistant or QA coordinator. And then the teachable caregiver that's on the Kaiser form, we kind of just went more into detail. So is there a willing and able caregiver? And if there isn't, is the MSW on service if appropriate? The diagnosis and identified skilled need. And then if the home environment is appropriate or safe for the patient, and then what type of an environment they're in. We continue to have the prior level of function, current functional status, current clinical status, and then we added the need for other services. So is this patient appropriate for hospice? Are there other disciplines that are needed on this case to be requested? And what's the status of that? Did they refuse them? Is that something that's we're waiting for auth for? Like, what's going on with the need and the implementation of those services? And then their current progress toward discharge goal, the need services needed after discharge. So this will help to address what I just spoke about, is that that 30-day time frame we have after discharge. What do we need to implement to ensure that after discharge they're safe and they don't go back into the hospital? Okay. And then we have the wound status. We don't really need the measurements on this because we have that in our charting system, but more so, what's the status of the wound? Is it healing? Is it stalled? Has the wound deteriorated? And then any comments. And then also, what other things are we doing for the patient? Are we doing PCINR, IV, Foley, etc.? The bottom of the form is the same as it is with the Kaiser authorization form, with the implementing what the frequency was, what was the pre-auth, how many more visits we need for this patient, and then what visits are authorized. Okay. So again, don't get overwhelmed just looking at this. We are figuring out, right now is what we're doing is figuring out how to implement this, how to implement it without causing added stress and strain on clinicians, but at the same time meeting the goal of this program. Okay. Any questions so far?
I have a question.
Uh-huh.
Yeah, I was just thinking, can I play devil's advocate?
Sure.
Sure. So the one thing I've noticed between, say, at least in my territory of Alameda County, is that my Medi-Cal patients and Kaiser patients totally different. And the Kaiser model for generally providing care is very different from, say, like Lifelong or Alameda Alliance. And so just like a couple of differences I noticed is that like Medi-Cal patients generally have like less resources, less social support. There seems to be also like less like healthcare literacy, and it's much easier to get a hold of doctors at Kaiser. So I don't know. I think apples to apples, it's tough to compare, and I think generally like Medi-Cal patients need more support from us than Kaiser in general.
And
I
you're
agree with
absolutely,
you. Oh,
yeah,
sorry. Go
Ray,
ahead, Joey.
you're absolutely right, Ray. I mean, almost if they're Medi-Cal, we almost have to make it automatic that they get at least an MSW out there. Whoever's opening case gets an MSW out there. And what this is, I mean, there's obviously we can't solve everything in the situation, but we can increase the heightenedness of we can increase the awareness of the situation and provide the service that we can provide. That means, closely managing their cases. That means, facilitating collaboration between the team to get, to get goals met as much as possible, as close as we can. Because we also know in that population, there's some behavioral issues, some emotional issues that gets in the way of meeting goals. But what we're trying to accomplish here is asking the question, are we doing everything possible for this patient? And if we are, and we still can't, get the outcomes that we need, then we're going to be able to live with that. But if what we're trying to avoid is that, we see them and not provide the service that we know we can provide. Does that make sense?
Yeah, totally.
Okay.
And all of these are going to be individualized based on the patient needs. So it's not like a prescribed number of visits and then, you exit. If you can determine and provide evidence of ongoing skilled need, of course, those authorizations will be approved and everybody will be on the same page. It is just to basically focus that care to make sure that we're providing everything that we can and try to reduce the number of overall visits, but then also increase the quality outcomes by discharge. And I believe that's possible. I know in particular our patients in Oakland tend to be more challenging, and we're going to factor all of that in.
Good question, Ray. Good question.
Yeah.
Any more questions? Go ahead, Keela.
That's all I have for this new program. Again, we'll have more education as we get closer to rollout. The full process laid out for you guys. Other than that, I think I have just a few more minutes. I just wanted to go back and touch bases on what Teresa had mentioned about missed visits, or not missed visits, but trying to contact patients for evaluations. We have noticed an increase in the number of missed visits overall, but also with evaluations. And so generally you want to have a 4-step process before you move on from attempting or doing a missed visit for your eval. You've called the patient at least twice. You've reached out to the clinical staff. You've reached out to the clinical staff that's seeing the patient, because if there are clinicians that are making those visits, like Tanya said and like Teresa said, reach out to those clinicians, see if they can do a phone call with you, or if you guys can arrange a joint visit with that patient. And then the 4th step, if possible, it's not always possible, but if possible, do a drive-by, right? Before you discharge that evaluation request. The evaluation is needed for a reason. So, we need to show and we need to document in the chart all of the steps we've taken to try to complete that evaluation. The other thing about missed visits is that we cannot say that we missed the visit due to clinician schedule. or clinician out sick. If you are out sick and that patient needs to be seen, then let the scheduler know the patient visit needs to be covered. And so that scheduler can work on getting it covered. If for whatever reason we don't have a clinician that can see the patient, we have to provide them the option to be discharged from services and referred to another agency, right? So if we don't have an ST in that area, that's the option that we can give that patient. And then if the patient does not want to be discharged, they want to stay on services and wait for a discipline that can see them, then we document that the patient did refuse discharge, wants to continue services until ST available. That is the only exception of documenting when it's, due to agency or clinician, is that we provided that option and the patient declined. So I just wanted to mention that. Any questions about?
Akila, it's Rose Strobridge. Can I ask you a question?
Sure.
Yeah, when can we discharge a patient, active patient that doesn't return call, not answering the door when you do a drive-by? I did it 3 times. Can we discharge the patient right away after 3 sets?
Are there other clinicians seeing the patient?
No, supposed to be an MSW, but I don't know what happened to Jamie. It's been a month.
Okay, so anything of that MSW should have been reassigned to a different social worker. So if you want to text me the patient's name after this,
I think
your-
it was assigned. She's a girl. She's been assigned to Maria, but she is not answering the phone. That's a problem. Even me, I only visited her twice, and then
Yeah.
after that, she never returned my call. I did 2 drive-bys. She's not at home. Can I discharge her now? It's been a month.
No. The only other thing I would mention, I would say, is, have you contacted her? Does she have a DPOA?
Yeah,
Does
I
she have
texted.
a family?
No,
As part of-
no.
No. Then
Not
you
even someone is answering my call.
Right. So then at that point, you've called, you've done drive-bys. There aren't any other clinicians that are able to see, that are seeing the patient and you can reach out to for assistance. So at this point, I would reach out to
Yeah, I
the
don't be
physician.
already tried to contact her.
Right. So I would reach out to the physician to obtain a DC order and discharge the patient.
Oh, okay.
Yeah, I think the general answer to your question, Rose, is if you have that situation, please reach out to Tanya, Akila, or myself. We'll take it case by case basis and guide you through that. Okay.
Appreciate that. Thank you. All right. Joy, you're going to talk a little bit about the interpreter services, which is already been introduced, but we want to make sure that the staff is aware as a in whole.
Sorry. Hi, everyone. I just wanted to get input from everyone how it's going and make sure that you aren't having any problems. I am trying to send tips and tricks email every week to try and improve your skills in how to use that service. So any input is appreciated. Thank you. Anyone?
I do have something to say.
Yes,
Okay,
Teresa,
when
please.
we call, I'm sorry because I'm using it a lot. So when we call, how do we put it on the speaker? Because it's really hard to hear the other person. And I don't know how I click the speaker. And then if I click the speaker, it goes mute. So how do we put it on the speaker so we can make it loud?
Okay.
If you can send me instructions, that would be great.
Absolutely. Is anyone having the same issue?
Upper left corner, there's a
Okay.
speaker sign.
Oh, thank you. Upper left. Great.